Matthew, no, non si sentono ancora.
C'hai le sirene. I think that we are live right now. So hello, everyone, and welcome to the first International Osteocom live event in collaboration with IAO, the Italian Academy of Osseointegration. This would be just the first one of a series of live events that we are going to broadcast on our Facebook page. So if you are willing to receive news and updates regarding our live streaming program, you just need to follow our Facebook page or just get subscribed for free on the Osteocom platform. I am Mattia, and I'm part of the Osteocom team. You might already know our platform, osteocom.me, an e-learning dental platform which has always dealt with learning and innovation. And by trying to combine these two elements, we offer video courses with unique educational programs that we developed together with the authors, with the key opinion leader, and which are mostly the most respected key opinion leader in the dental community. Talking about our key opinion leader, we will host today live discussion with three worldwide renowned experts. We share their own professional knowledge and experience. And so we are very, very, very proud to present a case discussion with Dr. Iñaki Gamborena, Professor Giovanni Zucchelli, Professor Jose Nart, moderated by Dr. Alberto Pispero. I'm happy to see that there is a lot of people connecting to our live streaming, and so I don't want to lose too much time, but I'd like to steal 2 more minutes to talk about a solidarity initiative that we activated on our platform. The solidarity initiative is called Digital Solidarity, and it is supported and promoted by the Italian Ministry for Innovation, Technology and Digitalization. Basically, we thought that in order to turn this period of time, this time that we have available now, into an opportunity of professional update and growth, we should do something for the dental community and for the Osteocom community. So we decided together with our authors to give some of the classes, some of the lessons that you can find already in the platform for free, which means that actually you can activate for free those lessons and keep them in your personal library in your account on Osteocom forever. To reach this initiative and to reach the page of the Digital Solidarity, you can directly go to the platform, to Osteocom platform, and choose the Digital Solidarity category in the menu. Otherwise, you can just follow the links that my colleagues in Osteocom are sharing in the comments to this live streaming. So just two last things that I would like to remind you, two last things that actually regard the discussion of today. If you would like to ask some questions to the speakers, you just need to type your question into the comments box of the live streaming, and we will submit it live to the speakers, so they can actually answer to your question in the real time. I'd like also to suggest you to share the live streaming on your personal Facebook account page, so you will be able to rewatch it and watch it whenever you want, whenever you wish. You can also find the videos of our live streaming on the Facebook page of Osteocom in the video section. So let's go to the discussion now. I leave the floor to Dr. Alfonso Caiazzo. Ciao, Alfonso.
Ciao, Mattia.
Who is the president of EIO and who will greet you and before the live discussion. Thank you and enjoy it.
Thank you, Mattia. Dear colleagues, good afternoon. Thanks for being here and take some time and thank for taking some time for your time, I guess, at home and sharing some time with your family and taking 2 hours to spend with us. On behalf of the Italian Academy of Osseointegration, I'd like to thank the outstanding participants to this event. As Mattia said, Professor Jose Nart, Professor Iñaki Gamborena, and Professor Giovanni Zucchelli. It's an honor and a pleasure to be hosted on this platform by Osteocom, so I want to thank Osteocom as well. And as Mattia said, this is the first international event, so we're very proud to be part of this event and to be the first scientific association to be involved in this event. So for us, it's an honor and a pleasure as members of the Italian Academy of Osseointegration. I have to thank and especially Dr. Alberto Pispero for the outstanding work that he's carrying out in this tragic moment to give some release. He has been working on this project very hard, and he put up a very incredible program of events, broadcasted events, and this is part of the work he has been doing for the last month or so since we've been locked out. So I don't want to take more time out of this great event, and I'm sure we will enjoy this hour and a half, and I think it's a great opportunity for everybody to see these 3 outstanding experts giving us an approach to a single case and see different way of approaching a case. So thanks again to everybody. Thanks Osteocom. Thanks to the speakers. And Alberto, I will give you the opportunity to introduce the case and to talk about our projects as well. Thank you very much. Bye, everybody.
Thank you, President, and good afternoon, everyone. Buenas tardes a todos. Buon pomeriggio a tutti. You are so many, thousands of you are here now connected. So I'm very honored to be part of this big event, and I wanna share with you our project with our society, the Italian Academy of Osseointegration. I asked to Alessandro to show us now the picture of our program of the next week. And so, as you can see here in this moment, you can connect to the page, our website, www.iao-online.com. And so if you connect it here, you can access to a lot of video lectures and live guest online discussion. As you can see, most of the lectures are in Italian, but in the next few days, they're going to be translated in English. So I never imagined to be a dentist in smart working, but we are here. This is our office now. And this is the moment in which Italian Academy of Osseointegration and Osteocom are together to share with you our experience, to share with you the expertise of our big society. We have most of one of the most important dentists in the world, and also in our society there is a very, very incredible young group that I waiting for all that they do all the time. So now I want to show you the picture of the case that we want discuss today. I want to show the picture of the first picture, as you can see here. Yes, perfect. And so here we have a patient that came to the office of the owner of this dentist, and as you can see here, there is a big problem on the first incisor on the right side, upper incisor. And so we have a loss of the soft tissue and also of the hard tissue. And we have the loss also of the papilla between the implant and the lateral incisor. What happened to this tooth? It was extracted because of a trauma, a fracture, a vertical fracture of the root. And so after a few years, we have complete resorption of the soft and hard tissue. And so this is a failure. This is the picture of the X-ray. You can see in particular the CBCT. There is no problem on the palatal side, but we have from this view a complete resorption of the bone from this side. As you can see, the crown is a composite crown on a titanium abutment, and the soft tissue go apical to the coronal part of the implant. There is no bleeding in this implant. The interproximal bone was almost completely lost, lack of distal papillae, no buccal tissue, minimum gingiva, close proximity of the root of the lateral incisor to the implant. But I'm going to show you what happened when we remove the crown from this implant. There is a complete resorption on the horizontal plane of the soft and hard tissue that you can better see from this view. And now the question is this implant position restorable? And I'm going to ask you to our speaker what they think about this. And I'm going to invite the Professor Zucchelli and the Professor Nart and Professor Gamborena, and thank you for being here. And now all of us want to know what you want to do in this case.
Hello, everybody. Thank
Hello.
you for this kind invitation. It's a great honor to be here next to these big guys like Giovanni and Jose. And I think it will be really interesting because we have different approaches, different backgrounds, so it will be interesting interaction.
Thank you, Iñaki. Thank you, the Italian Academy of Integration. Thank you, Giovanni. Thank you, Stockholm. And Alfonso for setting this up. We're going to spend a fantastic hour discussing scientifically this outstanding case. So I'm very happy to be here with you guys.
I am so happy because you accepted the invitation of the Italian Academy of Integration in Stockholm to attend this virtual meeting, and it will be really nice to argue and to discuss with you. And since we are friends, I hope that we'll remain friends also at the end of the webinar.
No question, Giovanni.
No question, yes.
Thick-skinned, don't worry.
I don't know, I can start as usual, because the big problem of this case, obviously, is the complete loss of the distal papilla of this implant and the very, very close proximity of the implant head to the adjacent tooth. And this is obviously the most difficult challenge we have, because what the patient is much more interested, I think, rather than coverage of the buccal aspect, is to rescue the inter-implant papilla that I don't know if she or he has never had, but for sure, this is the most difficult situation. And I have to tell you that when I see this case, I really start to think about implant extraction, because you know, the possibility to rescue the papilla, the mesial one is very, very good, but the distal is completely lost, and the very, very close proximity of the tooth makes also soft tissue management very, very difficult and not so predictable. And so the first thing I would like to ask you also, before you tell what you think about this case, is how much is predictable, how much is possible, in your opinion, today to unscrew this type of implants that are very, very good integrated into the bone with the tools that we use to unscrew the implant? Because just yesterday, I heard during a webinar that today we can unscrew very predictably this implant with more than 90% of the clinical case. And I really want to share with you if you agree or not with this number. We're just speaking about numbers, but it's not obviously evidence, just your opinion.
Yeah, Iñaki, go ahead.
Yeah, go ahead. Well, for
Okay.
me, I guess you're right. The main problems that I have had to unscrew an implant on the maxilla, it was always when I had an implant that was maybe anchored to the nose or to a really strong bone, you know. But usually I don't have as many problems on the maxilla as I do on the lower teeth. No, I think maxilla is more forgiving because of the quality of the bone. But it's true that sometimes even in the maxilla, if those implants are anchored to the base of the nose or to the angle of the cortical bone of the sinuses, sometimes it's difficult. But usually I don't find too many problems in the maxilla. But on the mandible, I have had several problems. Regarding to this guy, I think is so big and so wide. I think I have more problems with narrow implants to extract them out because sometimes it breaks. I have limited problems with wider diameter implants. I don't know what is your experience, but with wider implants, it's easier on the paper to extract them.
Yeah, Iñaki, I would certainly agree. With wider implants, there is less buccal bone present normally, and the implant itself does not break, does not fall apart. With narrow implants, it is true when you apply the torque, the removal torque, it sometimes opens like a flower, and then you get a problem for the most apical part. If it happens in the mandible, then it becomes very tricky.
I think extracting this implant shouldn't be too much of a problem. I think having used Giovanni here, the biggest problem is, as we all know, is not the buccal recession, is when this buccal recession is affecting the interproximal. This is a totally ball game different approach because this is where we have the highest difficulty is to bring back all of this. I was thinking if you already say that you will extract the implant, but we have to evaluate all the risk. If you extract the implant, how are you going to approach it? How are you going to do it? Which type of incision are you going to do it? Are you going to bone graft? Are you going to leave the lateral incisor? Are you going to extract at the same time the lateral incisor? How would you approach, for example, Giovanni, how would you approach this case if you ever have to extract the implant? Because the most important in this situation, in this case, is not about thinking that you might do, is about the sequencing, and all the details are really important because here we cannot fail. This is the issue, that the 1% possibility of failure is too high of a risk, you know. So I don't know, there are many big guys in bone regeneration. But to tell you the truth, this one is a complex one because there is no tissue. So I don't know, it's really tricky because all of us can maybe tell the patient, well, I will extract the implant and place 2 implants. You know,
yeah, I think
placing 2 implants in this case is really difficult because the lateral is minuscule. You know, it's like 5.5, not even 5.0 mesiodistal. So space is an issue also in this case to place two implants together. So if you do bone grafting, are you doing a 4-unit bridge with two pontics? I don't know. Just think about it.
Yeah, I absolutely agree. And yeah, you say?
I was going to tell you honestly what I would do when I first would see this patient. Not what I would do, Iñaki. I think this needs a very thorough plan because of the papilla. But the first thing that would come to my mind, as Giovanni has said, would be the extraction, explantation of the implant, provided that I can remove it without raising a flap. Because Iñaki, you said it, if you raise a flap in this situation, the distal papilla will be even shorter and even more compromised. So if I'm able to unscrew the implant without raising any flap, inserting a mineralized allograft, no flaps, just to fill the space that the implant is occupying. If there's no buccal plate at all, I would tunnel a cross-link membrane, insert an allograft, and let it heal, soft tissue closure. But I'm assuming at that moment that I will need to do another regeneration, either bone or soft tissue at the time I place the new implant, and of course, ortho treatment in the whole mouth, particularly for that area, and doing extrusion. This is the only way, if I have no teeth in the central, that I can extrude and gain papilla. So it becomes a very challenging treatment plan, and of course, I'm obliging myself to do probably 2 or 3 soft tissue grafting for the area. I'm just guessing. But the first thing that would be the first thing that would come to my mind. Extracting, because it's a very wide implant, and everything that I would do outside the buccal area of the implant, it's outside the bony envelope or very limited. So it does not seem very predictable to do anything outside this implant. Now, with soft tissue, we can do several things, and we'll discuss it.
Alberto, can you please augment the magnification of the X-ray, not the cone, being that we don't care, but yes, this is very important, I think, because, you know, I absolutely agree that we cannot make mistakes, because this type of patients are patients that they are very, very angry. They are very, very disappointed because the previous treatment was a failure. And so we cannot make another failure for this patient. So we have to be as much as predictable as possible. And when we face such a case, I think that predictability is something that we cannot mention at all. And so it's our experience that maybe will help other clinicians in order to understand what is the best thing that we can do. And I'm really afraid about the very, very close proximity between the root of the lateral and the implant, and the presence of very, very short root. So in my opinion, if we have to extract this implant, I would do nothing the day of tooth extraction and try to be as much as minimally traumatic during the implant extraction and leave the soft tissue here, because I think that in this time, at the time of the implant extraction, the amount of bone on the attachment we can find at the level of the lateral, it's so poor due to the proximity that it's better to wait for the attachment and the bone to remineralize in order to do whatever other type of treatment at the level of the lateral. Then, once this is transformed in a dentulous site, I know that this papilla is going most probably to recede further, but we can also use the extrusion of the lateral or soft tissue augmentation procedure in order to improve the edentulous site. And I'm not so sure that bone augmentation can make the difference in this type of implant treatment.
For example, I have a question for you, Giovanni. I will tell you, if I will extract the implant, I will never place bone, neither membrane. I wouldn't do anything because I'm risking too much.
You don't have soft tissue to close it at all.
This is the issue. So my question to you is, would you do a graft already at this time?
I have to tell you that I don't like it because, you know, for the same reason that you don't have soft tissue to cover the bone, you don't have soft tissue to cover the graft. And so to leave the graft exposed means to take a big graft, to leave a scar, to make very, very different color healing. So what is the sense to make the graft at the time of the implant extraction? I prefer to leave the soft tissue here and then to use the soft tissue in order to cover the connective tissue graft.
You will still have a huge collapse of the buccal plate and even more tissue loss, that's for sure. But I think we all agree, I don't know, Jose, you will still place a membrane and a bone?
My approach would be as if I'm extracting a tooth and I'm doing ridge preservation. And
but the problem is how to close it. You have big different heights on the implant. You will be even go higher. How you will
And the ridge preservation, you can do it if you have the buccal bone, but I'm not sure that you have the buccal bone, so it becomes ridge augmentation. And so, you know, I think that to cover the hard tissue, it's really, really, really a big, big issue.
So I think if we extract the implant and place some collagen plugs and do nothing, I think maybe is the most reasonable thing to do, I guess, for me. Then what would you do? How long would you wait? Then which type of approach you will do? You will extract the lateral to do a bone ridge. You will use an orthodontic extrusion to bring the soft tissue to a more coronal position, then to be.
I think that extrusion, it's something that we all love in this case. But the problem of extrusion is that, first of all, we have to find some bone between the tissue, between the implant and the tooth, in order to extrude bone and soft tissue. If they are so close, I think that also tooth extrusion doesn't make so much difference. So the problem is if you are able to gain some tissue, because, you know, what really makes me absolutely worried is that this implant, it's so large in the neck.
Yeah, it's huge. It's like a 5 millimeter.
Yeah, because I would like to, let's say, if it was possible to reshape the head of the implant in order to increase the space between the implant and the adjacent tooth, and then eventually to make some extrusion.
Let's go to picture number 4, so we can see it from the occlusal view. I think the problem is as soon as you extract the implant, the lateral goes behind afterwards. You know, it's no possibility of extrusion or anything because it would
I want to be provocative. Why don't you extract the lateral only? And then you make soft tissue augmentation of the dentulous area and also of the implant site, and then you use the implant with a pontic instead of the lateral.
Yeah, maybe this approach.
People will kill me for this, you know.
No, not at all. For me, it's a great idea. To extract the lateral. The problem is extracting the lateral means that we will have to do maybe a ridge preservation the day that you are extracting the tooth. You will do an extrusion just to bring as much tissue further coronal, and then extract it with the orthodontics and do a ridge preservation with.
I was thinking exactly in this way, to extract the lateral orthodontically. So to gain some tissue and eventually some bone, and then to make soft tissue augmentation only.
Maybe another good idea would be to extract the really slow orthodontics, like 1 millimeter every 2 months. No controlling of occlusion. Bring it down, just to bring as much facial soft tissue coronal to really be able to maybe graft before extracting the tooth, to graft maybe the implant on the buccal aspect, because then you will have tissue on the sides in a better location maybe, and then be able to graft the implant buccally as much as possible and maybe crestally, and then extract the implant, do the tooth, then do the bone regeneration of the lateral incisor and graft it with soft tissue. Maybe this approach I would like it better than
Iñaki,
jumping, because this implant doesn't have periimplantitis. So
I want to ask a question from from a colleague. What about amelogenin on the lateral root after implant removal?
Giovanni, you're laughing. You want to answer? No, it's okay.
No, I absolutely agree that if we want to keep the lateral, the use of amelogenins in order to try to rescue some gain of attachment is something that we can do, but amelogenins don't work if you don't give stability to the blood clot, and if you cannot cover, and if you cannot give stability with the soft tissue. I don't think that amelogenins itself can make the growth of the interproximal attachment on this tooth. So the big problem, and I really, Jose, I really want to understand, what do you think about?
Yes, exactly. I wanted to explain myself further. When we do ridge preservation, we do it very often. In fact, when it adds value, ridge preservation, it's when you do not have buccal plate, when there's a missing buccal plate. So what we do in those cases, very minimally invasively, we generate a membrane with a J shape. So we're missing the buccal plate, we're going to tunnel the membrane, and it's going to be folded palatally without raising papillas. It's just going to be a J-shaped membrane.
So you leave the membrane exposed?
Absolutely exposed. Soft tissue coverage. And it's a cross-link membrane. Of course, we cannot manage this soft tissue as it is at all. And I use not a xenograft, but an allograft, mineralized allograft inside. And I use a cross-link membrane resorbable outside. And it, you lose, obviously, it is not maintained with integrity, and it's resorbed during the first 15 days. But you have a coagulum stable inside, and you don't get such a collapse.
Yeah, but the big problem here, Jose, is that you don't have tissue in the buccal. I agree with you if you had some tissue in the buccal, but here I don't think it's a great idea. You don't have any.
And I also have some doubt about the mesial papilla of the lateral, because I know that this membrane can be left exposed, but in the case of some minor infection, if you can also lose some more height of this papilla, it's really a disaster. So I think that we have to do something to improve soft tissue between the implant and the adjacent tooth. I think this is the main goal. Whatever is the decision we can take. And I read some nice questions. They say, do you extract a healthy tooth in order to keep a questionable implant?
I would never extract the lateral incisor, Giovanni, to be honest.
I wanted to be provocative, just to understand. But at least theoretically, it's easier to restore the area of the lateral, which has a very, very short root and the intact buccal bone, than the area of the implant that has, so many troubles. But I absolutely agree that if we can avoid the extraction of the lateral, we are all happy. But the problem is, how can you gain tissue between the implant and the lateral incisor?
I think orthodontically, you are right. Orthodontically, we can upright distally the lateral incisor to move it away from the implant. This is one option. We can reduce the diameter of the lateral incisor cervically to allow more space, more distance. So the orthodontist
just
can
one
really...
question to you. There's no way to reshape the head of the implant. Prosthetically, you cannot do it, in your opinion.
Look at picture number 4. Can we go picture number 4?
Alberto?
Yes.
You can see the distance between the hex and the outside is like 0.2. There's no more there. The connection is huge.
I see that there is some metallic before.
Yeah, you can reshape. Maybe we could reshape towards the buccal.
No, the buccal I don't care. But
I mean interproximal and towards the buccal, following the same angulation of the connection.
Yeah, because if you look at the X-rays, as much as you go apically, the diameter of the implant becomes smaller. So that's why I was saying, if you tell me that prosthetically you can solve this big problem that is reshaping the head of the implant, I know it's a compromise, but eventually we can gain tissue.
Absolutely,
and also
yes.
changing the inclination of the lateral orthodontically, we can gain some more tissue.
Yes. Then my question to you is, how much do you want? How much you will love to have in order to graft in between, if you have to? What is the minimum?
Tissue, you mean?
Giovanni, can you graft in the papilla area being with such a narrow space? Is it realistic?
It's maybe
At this spot?
1 millimeter, maybe there. Less, maybe.
Iñaki.
I have my personal opinion that the graft can be maintained covering the head of the implant if it only receives blood supply by a covering flap. In this case, if you leave a graft exposed occlusally on the head of the implant, it will never survive because it does not receive blood supply from anywhere below. So you have to cover, but the problem to cover in this case that you don't have also not good tissue at the buccal aspect. So one thing could be, can you improve the tissue at the buccal aspect first, and then eventually can you improve the soft tissue occlusally above the implant head using the implant site like an edentulous site and make everything closed by first intention? I don't think it's predictable to cover the connective tissue graft with such a bad tissue at the buccal aspect.
So I'm the patient. What are you gonna do?
Guys, do we all agree?
What is asking us?
Iñaki, do we all agree that we would never place a wide diameter implant in the front area?
Yeah, it's okay. Yeah, but
now it's late.
So
Yeah.
it's too late.
No, Iñaki, my second question is, you are aiming to save it and maintain the implant, but
no, I don't know. I don't know. I would like to see how will you solve it. Because the problem is risk assessment, and the most important determination is to decide which way we're gonna do and make sure that you cannot fail. So to decrease as much as possible the failures, and this is the type of cases where you look at on your daily practice. You come from a course, you go to on Monday, and you see this, and you say, "Wow."
Why don't we do, for example, we can change the angulation of the tooth orthodontically first, and see how much the tissue improve interproximally between the implant and the tooth itself.
Because this is what I would do. I would do, for example,
before saying anything to our patient. Yes,
what I would say to this patient, I say, listen, it's impossible. I cannot improve the situation without orthodontics. Why? Because if I don't need it, I still already told the patient that she needs orthodontics. So I think I try to do something on the lateral to find out, what you can do. And the first thing is to create a space.
Yeah, I think we all agree with that. Involving ortho, it's a need for this case.
If we don't want, for me, every time that I see an interproximal defect, the first thing that I'm thinking is about my orthodontist. Why? Because he's the best surgeon in the world.
Especially for the papilla.
Mm-hmm. Yeah, he can bring whatever I want that surgically it's impossible, or it will take 3 years to see the result.
What do you ask to your orthodontist first? Just to change the inclination, or also to start
to change the inclination and to see how much he can get away
the
from the implant, and see how
because what we can expect is some improvement not only of the tissue but also of the bone. As much as you increase the distance, maybe you don't see the bone, but there is bone.
When you upright, the movement is that the tooth will intrude a little bit, so it will be pretty much leveled. The buccal will be pretty much leveled, and see with the buccal aspect of the implant collar and see which is the situation. And then you will be deciding. You have to be really working really closely with the orthodontist, but I will never tell the orthodontist like a conventional thinking process that we all learned, extrude the lateral incisor. I think this is the worst that you can do. I will try to do, I totally against what I have learned. I will never do orthodontics before the surgery. I'll try to maybe upright, see how the orthodontist can put the tooth in the best situation that I can excel surgically. I think this is, for me, is the most important issue, that the orthodontist can really do things that I cannot do surgically. So I will put my tooth in a way that I can excel surgically and improve the buccal aspect with thick connective tissue, and then decide how much I need. Maybe I will do another second connective tissue and then decide upon that. I think extracting the implant, really, I extract the implant and I think I have a huge defect, and then the lateral, if I extract the implant, I will have to do something with the lateral incisor, maybe some orthodontics that will help me maybe to bring the tissue to a more...
Yeah, but we have also to look at the root of the lateral. That is very, very short.
Thinking that I will lose it. No, if I extract the implant.
So I think that also implant extraction can take advantage if you change the inclination of the lateral, because by changing the inclination of the lateral and waiting for the bone and the soft tissue to come back, we can be also less traumatic at the time of the implant extraction with respect to the lateral.
How would you approach this in your case? How do you sell this treatment to your patient? You know, this is interesting. You said to the patient, "Hey, listen, you came to me because you heard about things, but
because really, you have to tell the patient that
we have to leave an open door. You know, we don't know which way we're gonna go. We will try to go this way. Maybe
you are also asking patient to make 4 or 5 months of orthodontics in order to change the inclination of the tooth, and then you decide, I don't know what to do now. I have to extract.
But here we are three guys, and that we try to provide the best out of this mess. You know. And then what I think is the most important is to leave open doors to us. And I say, listen, I will need maybe some orthodontics. I don't know how much, how long. This treatment is going to take 3 years. Okay, ciao. I want to see somebody else. So it's true. How would you approach it?
I think that I would ask my patient to have some orthodontic to change the inclination of the lateral, and then, which will last 5 months, I don't know. And then the patient has to leave me the possibility to change the treatment plan according to how much I will gain with orthodontic.
So my question is, you will take the implant out, or you will do the orthodontics without extracting the implant?
Yeah, without extracting the implant.
So you will keep the implant and...
Yeah, because in my mind, let's say, sometimes by repositioning of the root in the right position, because it's true that it's very close, but it's also true that the lateral, it's not in the right position in terms of root.
Another thing, Giovanni, is that you can improve even more the space doing a stripping on the mesial aspect of the canine. You know, so you can even gain more space, or distal to the canine and move the canine. I wouldn't like to move the canine.
Because, if the soft tissue improves between the implant and the adjacent tooth, I have eventually 2 options. One is implant extraction, but now it's easier to restore the dentulous site. And the second is, why not, if I have a good papilla, even if it's flat, I can use this papilla as a vascular bed for the graft.
Yes.
You might be convincing me now. You might be convincing me now. So we all agree that we would move distally the root of the lateral incisor to create more space eventually for a grafting.
Yes.
You see the lateral.
So why do you don't want to extract the implant now?
Because it's too close, in my opinion. It's too close.
No, it is smart what Giovanni is saying. We could do first ortho movement and then see what we have gained on how far we are and how the space we have for grafting, and then at that moment decide on extraction or not.
I think what is clear, did you change your mind, Jose? If you extract the implant, you will put some shit in there or not?
No, I'm telling you, you have to try allografts. I mean, there's very little use in Europe, but Americans who are watching us know that it's a great material. No, apart from jokes.
Americans are not a reference either.
No, I said that the first thing I would do when I would see the case would be extracting, but with a deeper discussion. I think that maintaining volume, it's very important, as you guys are saying. And then, yeah, let's go for ortho first. Let's distalize the root and see the space we get for soft tissue management. Let's see how it goes after ortho. Yes.
No, I was just kidding with you. I think
allograft
has more. I think I would have used allograft with membranes. I agree with you, but I think what I'm scared of is that the problem is the verticality of the tissue that is none, you know. So I have to pull so much that I'd rather extract the implant, see what is left, and then play it around with orthodontics to try to improve soft tissue wise before I do another graft in there. And which type of prosthetics are you gonna do? Are you gonna place 2 implants? I don't think it's an option, you know. Maybe bank the root,
most of the colleagues,
and place a 4-unit bridge.
Sorry, most of the colleagues are asking for a connective tissue graft. They all agree about a connective tissue graft. So all they want to maintain the implant. And so we want to know if
connective tissue graft is a very nice word. It's a very nice word. It's very, very fashion today. But the problem is that you have also to cover it. Because connective tissue graft itself doesn't mean so much in a case like this. Because where does
so Giovanni, I have a question. I have a question for you, because I want to take advantage of your dexterity and ability. No, I'm not bullshitting. I'm just telling the truth. So let's figure out that we decide to keep the implant. Okay, so we are all in the same page. We're gonna do some orthodontics before to see if the orthodontist can improve the mesial aspect and bring the root as far as possible with an upright without extruding the tooth. We just agree on that. And then let's imagine that we improve the space, Giovanni, and that the orthodontist is leaving you 1.25, 1.
Yeah, 25, it's okay.
25, yes. And then you have a little bit of more tissue. Then my question to you is, you have the same situation that you have in there, but you have a little bit more space.
And you know, I know what
the festoon is flatter. The scallop is flatter. You have the space. Now you have 1.5 millimeter space between the root and your implant. How are you going to approach this case? Where are you going to place the incisions? Are you going to use a cover screw?
Let's say,
are you going to close it?
May I see the picture of only the tissue only, not the X-rays anymore? Alberto, solo i tessuti molli. With no crown, please. Yes. First of all, I would remove the crown before making the surgery.
Sorry, this one.
Yeah, of course. It will be.
Yeah, of course. But some people in the world like to make surgery with a crown. Alberto, no crown.
No crown. Okay.
Last one.
Yeah, crucial view, Alberto.
Last picture.
Okay.
Yeah. Right there.
Okay. Let's think or imagine that we have a sort of papilla. So wider distance between the implant and the lateral.
Giovanni.
Yeah.
We're discussing something and we haven't discussed the most important. Is this implant restorable? Is depth and angulation perfect? Because we're discussing things here and say, well, wait a second.
I think that the angulation is the last problem of this implant.
Yeah. In fact, Iñaki, I was going to ask you.
Answer, no?
Yeah. I was going to ask you, you're supporting maintaining it from the beginning, but what if the angulation is more towards to the buccal? Would you still try to?
No, I will take it out.
Okay.
I think if the angulation is
no doubt,
if the angulation is coming in on the gingival margin,
outside the margin, it's gone. Yeah.
You know,
we agree.
We recently did a classification where if the implant is outside of the line and there is no papilla, maybe this is the only situation in which the implant has to be extracted 100%. because, you know.
Yeah, I think angulation is important, and it depends restoratively.
But this angulation is not bad.
No.
This angulation is not
it's
bad.
not
Limit.
bad. It's incisally.
Yeah, obviously.
It's
we
fine.
can do.
Acceptable.
You can see that is within the contours of the adjacent tooth. You know.
Yeah.
You can see the contour of the
absolutely
of the central is within there.
Yeah. In order to answer to your question, Iñaki, I don't like at all the tissue that I have buccally to the implant. So one hypothesis could be to ask the patient to make two surgery, one to improve the buccal aspect and then to improve the occlusal aspect in two different steps. That's something that I like to do most of the time when it's situation is so questionable, because with the second surgery, you can also repair some small
defect.
Yes. You know, defect that you leave with the first one.
So the first one, on the first one, where would you place the vertical incisions?
The vertical release incision is distal to the lateral, 100%, trapezoidal incision, distal to the lateral. And the second one, the central, I can also use mesial to the central or distal to the central. Doesn't change so much because the central is very, very good teeth. And the only reason why I can change the position of the vertical release incision is because I don't want to make a vertical release incision between the two centrons, so I prefer to shift it distal to the central.
Giovanni, even in this case, you would place two vertical release incisions. I cannot believe you. Would you? Two vertical.
Well, he has big balls, you know. So he likes.
You do have big balls.
You know, the problem is that you have to reach the palatal aspect. If you want to improve the occlusal aspect, you know, if you want to improve the soft tissue in the dental site, you have to reach the palatal aspect in somehow, because your flap has to close to the palatal tissue. That is the only tissue that can give blood supply to the buccal flap. And so to reach the palatal aspect of the tissue with such a wide implant in the middle, I think it's very hard to do it with no vertical release incision. But, you know, maybe one, it's enough. I can also make distal to the lateral and only an envelope type of flap in the second quadrant.
I have few questions, technique questions. If we do vertical incisions and we keep, I think the wider the flap, the more difficulty you will get to get into the narrowness of the and go distal to the implant. I have another
flap
question.
Adaptation.
Flap adaptation will be in the mesial will be tricky, you know, because if you are too wide, then you will have kind of a
but the problem is that if you don't elevate the papilla between the implant and the lateral, so if you tunnelize, you know, how can you cover the graft in this area?
No, I mean, because usually what you do is you don't elevate the flap, you don't elevate the tunnel, because then you will have a heart attack if you elevate the papilla. So usually you de-epithelialize it and you go above that tissue that is already there.
But in this case, I would make another technique that is not exactly what you are saying, that I call the platform, the connective tissue platform technique. I make a buccal flap, I make a split thickness lingual flap, I move the buccal flap to close by first intention to the lingual flap, and then I use many graft occlusally above the implant site and buccally at the buccal aspect of the implant in order to be completely covered by the coronally advanced flap. But in order to reach the palatal aspect of the dental site, so the implant site, I think that you need at least one vertical release incision if you open the buccal flap.
Personally, I think in order to close all that palatal, you have to make two releasing incisions. But I'm not sure
the mesial
that
papilla
I will
is very
go.
good. The mesial papilla is very good, so most probably there is enough advancement of the flap, even if you make an envelope flap.
What about you will place a cover screw?
Oh yes, you know, I will place just something to cover the hole, but the less space as possible.
Every time
but the problem is, do we want to do it in one stage and so try to increase buccally and occlusally in one stage, or do we want to increase buccally first? Because if we want to increase buccally first, we don't need any vertical.
It is not realistic.
It's impossible.
Giovanni, I think you're the only one in the world who can do who can do it
Both.
one stage. So, and I think you probably do not either. So let's go for the buccal first, I think. And if we go for the buccal.
No, yeah, the reason why I do the buccal first is because I don't like so many scars in this tissue, so many, let's say, very, very thin tissue, the complete absence of thickness. And so if I have to improve only the buccal aspect, I don't need vertical release incision. I just keep the old tissue interproximally, the old tissue, and I just make an envelope type of flap because I like to elevate a flap, but most probably you can also envelope a graft. The only problem of the envelope graft I have is that I'm not sure I'm able to keep the graft as corner as I would like. And when you envelope the graft tends to go apically.
I have a question for you. How do you manage these cases? Do you do any kind of therapy before you do your surgery? Do you clean it? Do you do something? Do you do you have an ideal situation?
Yeah, the best thing that obviously patient has to make oral hygiene, instruction, motivation, and the mouth should be perfect. But I think that the mouth of this patient is absolutely perfect. The only problem of this patient is the previous dentist. No problem of periodontal disease, no problem.
Actually, he was in Geneva.
Yeah, that's why.
Iñaki, you mentioned there's no bleeding on probing and there's no probing depth. So not much to be done regarding implant decontamination.
I think this is a very young patient. Yes. How old is she? Or
40. I think she was 34, 40.
So she's very young, completely healthy, I believe, from a perio point of view. So yes, for sure. The only thing that I have to wait is after orthodontic repositioning that this papilla will get better. That's the only thing that makes me really change the treatment plan.
Let's go back because I want to have it clear in my mind. Now do you have thought it thoroughly where you will place the vertical incisions?
The vertical incision distal to the lateral.
Do we want to see another picture or no? Yes?
No, I mean, I don't need any vertical release incision if I want to improve only the buccal.
Towards the buccal,
okay.
I can make an envelope type of flap. I'm sorry for you, but I elevate split thickness papilla between the lateral and the canine. I elevate split thickness papilla between the two central, and I move the flap and I advance an envelope type of flap, and I place a connective tissue graft, which will be completely covered by the coronal advanced flap. Because this is my way of making surgery. But
no.
Because this is the best way, in my opinion. Because
we learn from everybody. That's why I'm asking you, because I want to learn. You know, I know what you're gonna do.
I don't want to leave graft exposed.
Yeah, for sure.
Because leaving the graft exposed in this case is a big risk that graft don't survive because there is the big metallic below, and I would like to cover at least part of the buccal aspect of this metallic.
So you will use a cover screw
in the first surgery.
You will use a cover screw. For me, cover screw is always a problem. I always have a fistula. We all know that you have always a gap. You have an infection in there, especially with this connection.
But I'm speaking about the buccal aspect only at this time.
But you put a cover screw.
Yes.
And then the second.
So Maryland bridge.
Okay.
Maryland
then the
bridge.
Second. Yes, I agree. Second stage. Second surgery.
Second stage, if everything goes very, very well, I can make a flap that from the back. Let's say that now the buccal aspect of the ischions is covered by the connective tissue grafts. So I have to increase the papilla area. I have to make a connective tissue graft occlusally on the head of the implant that has to be covered. And the best way to cover is that my buccal flap is so free to reach the palatal flap. This is what I do in the case of soft segmentation of the dental site. But I'm here to hear what you would do without elevating the papilla.
Sorry, may I ask you a question about from the audience, because we are not considered now from the smile line of the patient. So if there is no inflammation, no bleeding, nothing, no problem with the surrounding tissue, considering the inflammation and infection of this tissue, can we solve this case in a prosthetic way? Is this a predictable solution? Is this possible? Can you consider this solution to propose it to the patient?
What do you mean, like adding a pink composite to the restoration?
Yeah.
Sorry for the expression, is a piece of shit. You lose the lateral faster. This is my opinion.
It's a compromise. It's a big compromise.
It's the best way to lose the lateral in a faster way. I think you will have foot impaction anyhow. Aesthetically, maybe the patient will like it, but in my opinion and in my experience, for the ones that I have done, I've been losing bone interproximally, and it's a
very difficult to clean.
Yeah, very difficult to maintain long term, and then you will have an issue of that you need to extract the lateral anyhow. So I think is a big problem.
Yeah, Iñaki, I would agree. There's already attachment loss to the lateral incisor. The cement in the interproximal area is exposed. Calculus, biofilm and calculus will accumulate very, very easily. This is true, but it is also true. Yeah, we should accept that surgically managing this case is for limited clinicians, very well trained and very experienced. So I understand that people figure out other ways of solving this case.
Well, this is the type of case that you don't make money and you get grayer like me.
But if you solve it, you can take a lot of money by making courses.
This is also what Iñaki does.
So it's indirect.
So listen,
so it's,
Giovanni.
I think that the problem is that I think that if you solve the problem of this patient, this is the most happy patient of the world. That's true.
It's true.
Because this patient is a patient that is really very, very disappointed. It's very, very sad. He cannot smile, So I
want to a little bit.
Somebody saying whatever we do, it's a compromise. Yes, but if it's a nice compromise, the patient is much more happy than if it's a bad compromise. So because if you think that both implant and tooth is going to be extracted, let's say, you will have to make bone augmentation, you have to make soft tissue augmentation, you have to place one implant with one cantilever, and then there is also the problem to be solved of the soft tissue with the cantilever in order to create a pontic. So it's not easy also to extract both, because it seems that it's easy if you extract both. I don't think it's easy to solve if you extract both.
It is not.
What happens to this bone crest between the implant and the lateral if you extract both?
It goes up.
I think
all the way.
Many Italian friends that are bone oriented will extract the implant and they will extract lateral incisor same day.
I think this is a big mistake.
And I think this is a big mistake. And this is what I wanted to...
If you want to come, you are welcome. I had a meeting with him. I had a webinar with him 2 weeks ago, so that was very nice.
Marco Ronda, where are you?
Marco. There's a lot of people here. But the problem is that, yes, I think that you have the 2 bone picks, bone augmentation work very, very well, but the problem remains the same. What about the papilla? Between the implant and the adjacent tooth?
So Giovanni, when you're measuring, you would do an envelope flap. Would you raise the papilla between the implant and the lateral incisor? Because there's no papilla.
Because he has moved it.
No. We said that this papilla was improved by orthodontics.
Okay.
If there's no papilla, you cannot elevate a papilla. That's for sure.
Iñaki, my approach.
There's no anatomic papilla to be desepitalized. But if you have a larger space, you can use this papilla. Remove only the epithelium in order to advance your flap a bit more coronally.
I see.
We started with the point that this papilla is going to be improved. If this papilla don't improve, I never make any surgery.
Okay. Iñaki, on my side, I don't raise that papilla. I go for a tunnel technique, and if I need to do a distal incision, I do like a vista type of approach on the distal area.
Please answer to my question. If you are not able to elevate the papilla, because it's very narrow. How can you tunnelize it?
What I'm saying is that
Since
I'm going
it's so narrow.
with a vista type of incision, Giovanni. I go distal to the lateral incisor, and I go a vista type of incision.
But the problem is, how can you push the graft coronally?
It is true.
I have
to accept.
Whatever other approach, it's difficult to advance the
It
graft
is very much.
because
difficult.
I like my technique only because I'm able to fix the graft where I would like to have it, and then I advance the flap more palatally in order to give stability to the flap. But if you use other technique that don't elevate the papilla, for sure the graft goes more apically.
Giovanni, I might
the only thing,
Giovanni, Iñaki, I'm sorry. I can either do a vista on both sides or raise the papilla between the lateral and the canine and gain more access. But it is true that mobilizing that flap towards to the buccal when you do a tunnel approach, it is much harder, no question. And I accept that I might leave a little bit of a millimeter of connective tissue exposed. I might, yes. But it's a big graft, vascularized by
There's no doubt.
areas.
There's no doubt. If you use the tunnel procedure, you have to leave the graft exposed and pray.
This is what I wanted to tell you. A lot of praying.
It is true.
And then besides that, we don't know.
But it's an option. It's an option that in this case, I would also consider, I have to tell you, because sometimes if the graft survive, because there is enough blood supply coming apical and laterally, this also makes this graft unexpectedly survive, and this is very useful for you for the rest of your surgery. But it's always very, very unpredictable to leave the graft exposed because, does not receive blood supply at all because there is very, 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 very small vascular
I have a nice
bed
question.
below.
I have a nice question to both of you. Which type of connective tissue are you taking? You're taking it from the palate, from the tuberosity.
I have to. Wait.
Iñaki.
I know what you're gonna do.
You know what I say always. You know what I say always, that there is no tuberosity in the world. They are only in San Sebastian.
Of course. Listen. Don't get upset yet. The idea is that there are many ways to do. I learned surgery to take submucosal and fatty tissue and everything. So with implants, I think the two guys in the world that do dense connective tissue that started to think about dense connective tissue selection around implants were you and myself. Why? I want to ask you why you don't want to have any type of adipose tissue or any type of submucosal.
If I have to answer to your question, I will use my connective tissue for the buccal aspect and your connective tissue for the occlusal aspect. So in the second stage, in order to cover the head of the implant in the dentulous site, I would use the tuberosity if there is a tuberosity, obviously.
Okay,
I'm going to agree with.
Tell you about it.
Iñaki, just let me say something. Giovanni, I will agree with you. Sure. I cannot leave the tuberosity graft exposed. I would agree with you, certainly. So we'll go palate first, and then if I have to gain occlusally, I go tuberosity. Iñaki, I have a present for you. Exactly this week, we got the acceptance of the 1-year follow-up journal clinical perio on the comparison of tuberosity between tuberosity and palatal side. So that is my present for you. And let me tell you, if you take a CT graft from the palatal side, very superficially, it is as stable at 1 year as the tuberosity graft. This is what we got from intraoral scanning.
I agree. Whatever you tell me, I think I think around implants, the denser, better result you will get. Yeah. That's for sure.
That's something that we agree. Yes, that's very important. That's very important.
Really important. The quality of the tissue you are grafting from is really important. On teeth, I don't give it.
Sorry, may I ask you a question from
sure.
From Howie Gluckman? I will try to extrude the tooth to develop the interproximal bone. Then I will remove the implant and graft with Curie technique, which will have bone in better positions. This way I will have some papilla and will have an implant with good buccal bone. However, I will have a compromise, but a healthy one. I will do not soft tissue alone here. Makes no sense. And many colleagues agree with this with the words of Howie Gluckman.
Very respectfully,
we are not saying
from the moment you do Curie,
everybody.
you have lost the papilla you have created with ortho.
You know, what is nice is one of the best surgeon who makes the Curie technique had the webinar with us. How many weeks ago? 3 weeks, 4 weeks? I don't remember anymore. It's the Stabola, and he said that very rarely he used this technique in the frontal area. Or let's say it depends on the type of the defect. And so, yeah, we can speak, but this is obviously something that we cannot argue. We don't have enough information. And the only thing I want to tell is that we don't know for sure that there is no buccal bone at this implant, because the fact that you don't see the buccal bone because of the scattering effect of the implant, it doesn't mean that there is thin bone.
May I
Of course, Iñaki.
Say something? Yes, please.
Well, I think, Owe, for me, the biggest mistake is to do the extrusion, because this is the only chance you have to gain verticality. The problem is that a lot of surgeons don't understand that if you do an extrusion of the tooth, the quality of the bone you are bringing is really, really poor. So if you raise a flap, everything that the orthodontist was able to improve during at least 8 to a year, by the time that you have a remineralization of that bone, is worthless. As soon as you elevate the flap, only with the contact with the oxygen is gone. So I think you can avoid the pain to the patient to have the orthodontics done before you do the surgery. This is what we have learned. May
I see the X-rays?
Yes.
Just few seconds.
Yes.
Because you are so worried about the absence of the buccal bone, but if you look at the X-rays, can you tell me how much bone you have interproximally between the implant and the tooth? You say, oh, I don't have the buccal bone. Okay, I agree that you don't have the buccal bone. But what about the bone between the implant and the tooth? Do you have bone? Do you see bone there?
Yeah.
So in order to see bone, you have to increase the space between the tooth and implant and see if there is really bone, because the space is so narrow that you cannot see bone at all. And so what do you extrude? Do you extrude in order to gain what? That you don't know if there is bone or not.
You extrude nothing. And if you extrude...
So first of all, you have to change the inclination. You have to see that there is bone between the implant and the tooth, and then eventually you can extrude it. But if you extrude a tooth that is attached to the implant, what kind of bone you can achieve by extruding? That you, as much as you go coronal, the more the proximity increases.
I have another important question to Owe. If you do bone graft from a Curie, which I agree that is a great technique and people do amaze. Mm-hmm. The big problem if you do a Curie is just to thinking that you're going to place 2 implants. Do you think that this case with implants, adjacent implants, it will be possible to be restored to copy exactly what you have on the contralateral side? Remember, this tooth lateral incisor is 5.0. It's really narrow. So the position of the implant is really crucial. And still doing a 2-stage surgery and develop vertically what you need is really difficult. Maybe you will say, well, maybe we can do a Pontic, a 4-unit bridge, but I think restoratively, this case is really difficult to restore with adjacent implants. So just as the thinking process, I think it's important to have the perspective of the full picture of the patient.
Iñaki, if I may agree, we even have evidence. You can look at Jan Kosin paper, Journal Clinical Perio, Hugo de Bruyne group, that implants placed after block grafts in the anterior maxilla give the worst aesthetic outcomes. Why? Because the distal papilla becomes shorter and shorter.
Yeah, then is a technique sensitive approach. Maybe
I think that everybody.
I
think that we all agree that here there is no an evidence-based treatment. So most probably, if somebody is much better with bone augmentation, maybe the best solution is to extract the implant. I don't know, to extract the tooth and then make bone augmentation. Maybe for those who are more confident with the soft tissue, it's much better to believe on the soft tissue reconstruction once we increase the space between the implant and the tooth. I have to tell you that personally, I would never extract the implant and the tooth because I'm not able to make such a very, very good bone augmentation and soft tissue augmentation in order to give a papilla back to this patient. That's why I don't do it.
So Giovanni, how would you sell this? How would you sell this treatment to your patient? How would you say I will need
as I told
or two or three until I get to the point where I can make it as perfect as possible? How would you?
I think this is the best patient we can work with. This is the best patient because this is very sad patient, very, very frustrated patient, very, very unhappy. And so this is a kind of patient that really can accept 2-3 surgery in order to get the best outcome. But we cannot fail. So from one side, it's a very good patient. From the other side, it's the worst patient. But this is a patient that if you tell the patient, look, don't ask me how many surgery I'm going to do. Don't ask me because I will do 3-4 surgery. But I will give you a good aesthetic outcome. I think this is very, very good for the patient, even if you have to make 3 surgery. I think that minimal invasive is not the good approach for this patient because there's a lot to do. In both cases, if you decide to keep the implant or if you decide to extract it. But this is a very good patient because this patient is really desperate.
Yeah, even the problem is if you fail, then even if you fail.
If you fail, you're the guilty.
Sorry.
That's why from one side, when I see this implant, when I see how big it is, how wide it is, I thought, yes, it's better to extract this implant. But before extracting, I want to increase the space. I want to see the bone between the implant and the tooth. And once I see the interproximal bone between the tooth and the implant, I'm sure that the lateral has bone together with attachment, because yes, I don't probe it. You don't probe it for sure. There's no space.
Sorry, Inaki. Sorry. We have half an hour, and so I think we can jump through the case, so we can solve the case, because we have more than 3,000 people connected that are waiting for see more images. We
didn't treat it.
We didn't treat it. Yeah.
we sent it to Giovanni. We sent it to Giovanni. We didn't treat it.
So now we can see who is the owner of this case, and so we can jump into through the case, and then we can have some other step.
You can make them vote. Who is the owner?
Guys, in the public chat, vote. Who is the owner of this case?
Who is the owner of this case?
But you have only 2 minutes to vote.
Yeah. Totally agree. We will see.
So I would like to discuss the incisions. Which incisions we do each one of us? Okay, because I think this is interesting for the surgical aspect. You know,
I think that we can see the first part of the treatment, and then we can discuss about the incision. Yes.
Okay.
Did people vote?
So, yeah, Giovanni.
Did people vote?
Two votes for Giovanni, 1 for Gamborena, 3 for Giovanni, 4 for Giovanni, and then 50-50 Giovanni and Iñaki. No, the people didn't know who is the owner of the case.
Yeah, let's go home. Bye.
Okay, do you see it there? Yeah, do you see it?
Alessandro, can you share the screen? Yeah, I'm waiting for Iñaki, for the screen of Iñaki.
Wait.
So, guys,
Do you see my
the
screen?
owner of the case
see my
is
screen?
Dr. Iñaki Gamborena.
Do you see my screen?
No, but the people
Okay.
still voting Giovanni. I don't know why.
It says
He's always
here
the
that
evil.
Safari does not support the screen sharing.
Yeah, because you have to use Chrome.
Okay.
Through Chrome.
Okay, wait a second. So how do I do it? I go out and in?
So continue to vote.
discuss it?
Yes, continue.
So there's no
discuss.
final case any longer.
Okay, just 1 second.
So I can
You can discuss.
I can read for you some.
You can make some other question in the meantime.
A split crest around the implant could.
There was also Nissan connecting to us. Nissan Bicciaccio was also connected. Ciao, Nissan.
A split crest around the implant could extrude the bone block with soft and hard tissue. So a bone block around the implant, so we can extrude soft and hard tissue. It's very difficult to.
So do you want to keep the implant with the bone block?
Yeah, to repositioning the implant in order to have the best position of the implant.
They do a box segmental approach.
Yeah.
Giovanni, this is what they are meaning.
Yeah.
They leave the palatal periosteum and they do a buccal approach, segmented osteotomy, and then they move it coronally.
With the osteotomy, yes.
Yeah,
there was the same problem of the proximity of the lateral, I think.
Absolutely.
But it's really an approach that I don't know at all.
Yeah, neither me. I've seen it. But when there's such a proximity with the root and the implant, then it doesn't seem to solve that
key.
problem.
That's the key. This is the very, very important aspect that we all agree. That the key is that we want to see space and also bone and also soft tissue between the implant and the adjacent tooth. That's the key. Otherwise, we can discuss if we don't gain bone and there is a deep pocket mesial to the lateral. Now, I think that we cannot do more than extracting both, or I don't know, extruding it a bit and then extract it by extrusion. But if there is bone, it's a completely different story, because if there is bone mesial to the lateral and distal to the implant, if I see there is bone because there is enough distance, I think that my treatment plan can really change. Jose?
Jose? No more. There is also a question about our.
I won. I am alone.
Yeah, but we are still continuing to speak in English. So.
No. Now there is Jose.
Jose.
I'm sorry, Giovanni. Giovanni, I was saying that you mentioned it once already, but I think we can stress that we are not worried at all about the buccal bone on the implant. We're worried really about the papilla area. I mean, interproximal attachment loss is the hardest thing to gain. And surgically, we are unable. So we need ortho, yes or yes. But really, gaining horizontally, it is not an issue any longer when you're inside the alveolar envelope. So we're not worried
I
with that.
absolutely agree.
Yeah.
That's the key. Interproximal bone and papilla. But with no bone, with no peaks, with no attachment level, we cannot gain also the papilla at all. So we want to see that there is something between the implant and the tooth. They are.
Are you still here, Giovanni?
So, Giovanni, do you see
Giovanni. Something freeze, Giovanni. Okay.
Okay, we are.
Okay, perfect.
Do we see it?
Yes.
Okay. So now the problem is the incision. I did the case. So this is the main problem: the space between the lateral and the implant. No? The mesial papilla is not a problem. We all agree on that. So that's why we were just doing. I think I would agree with you to increase as much as possible the buccal volume. This is my first thought. And I told the patient that it would be impossible for me to. I was gonna try to maintain the lateral incisor and maintain the implant. And because it was no perimplantitis. The implant was too big, and actually she stayed because I was the only one that wanted to maintain the implant. I told her that...
That's another very important aspect. That's another very important aspect, because if the patient tells you, I don't care, remove the implant, I think that I'm much more positive toward this. Not because I want the patient select, but because if the patient says, I don't want to remove the implant and start to cry, you psychologically start to think that the best you can do is to keep the implant also, yes or not? While if the patient says, I don't care, remove everything, it's another story. Sorry, go on.
Iñaki.
No more Iñaki.
Oh,
Sure.
Iñaki mentioned he would place a narrower abutment, not a closure cap, and then start with the soft tissue grafting. This is what I understood. Giovanni, did you understand the same?
He's starting with with orthodontic repositioning of the root.
Okay.
Uprighting of the root, I think.
Before the first soft tissue.
I don't know. Maybe he did the first buccal. I don't know.
Yeah.
I think, for example, since it's not here, I can say that, in my opinion, it was much better to reposition the root first and then make also the buccal, because if the papilla improves so much, you can also improve a bit also occlusally in the first surgery, because you can place your graft more coronally.
Coronally, I'm saying you, and I agree.
No, but I think that it's much, since you decide to make orthodontic, it's much better to do orthodontic before, since there's no pathology at all. There's no periodontal disease, so there's no problem to make orthodontic therapy before. Like we do for the lower incisors, most of the time it's better to make orthodontic to reposition the tooth in the right position and then to make the surgery, because the surgery becomes more predictable.
Absolutely. So it's...
A friend of us, Giovanni Paolo Casentini, write, no way, no space between the implant and the tooth. So he wants to remove the implant, absolutely.
We all agree. He wants to remove the implant.
So Casentini is also hoping for ortho to give us some space between the tooth and the implant.
Yeah, also, I agree, because also if you decide to remove the implant, it's better to gain space before.
Because most of colleagues are afraid about the fail, because if you fail big, it will be a big fail.
That's why I'm trying to convince Giovanni not to raise the papilla between the implant and the lateral incisor, but you see, he still wants to raise it.
After orthodontic therapy.
Yeah. I got the point.
So
it has to be somehow
if you want to make a point about the discussion until here, no reshape of the implant. Absolutely, it was impossible. Reshape.
That's a question that I need an answer, because I think that since a compromise has to be chosen in any way, I don't know if it's possible to reshape a bit, because the most coronal aspect of this implant is not really necessary for any stability of the implant. But I don't know if it prosthetically can be restored after. This is something I don't know. Jose, what do you think? I don't know this type of implant.
You see, it's a tripod connection. So he's afraid that on the vertex of those, it may be too narrow, not for restoration, but for fracture, I think he meant. So what he said is that
risk.
He can do some...
You weak it too much.
Exactly. Enameloplasty on the lateral, and also stripping on the canine. So moving not only uprighting, you see not only
so
uprighting...
So you prefer not to touch the implant, but to touch the teeth.
Yeah, and he did, I think. This is what he was planning, or he discussed with the ortho, I think. So we're going to see it soon, hopefully. Yeah.
Yeah, I want to show you a picture of the occlusal view.
Okay.
Alessandro, sorry. Until we are waiting for Iñaki, can you show the picture? And my screen. Okay, perfect. I think that depends also because of this space of the implant, the inner space of the implant, so it's too narrow in this case. So if you do a reshape, so you can break in this case. This is the reason why Iñaki didn't suggest about the reshape. And so another question about the soft tissue. Both of you agree about the removal of the implant, and then when we remove the implant, no connective tissue graft in this moment. Absolutely. Oh, okay. Alessandro,
No,
can you
I didn't
remove the
say
share screen?
absolutely. I say that most probably.
Thank you.
What do you think, Jose, to make a graft simultaneously?
Because sorry, most of the colleagues suggest about the roll flap from the palate, a pedicle flap from the palate. So if you can't cover the free connective tissue graft, you can use a pedicle flap from the palate.
You know, the pedicle flap from the palate risk to even worse the papilla situation, because the area that connects the palatal tissue to the buccal tissue, it's so narrow because there is no papilla mesial to the lateral. So I don't know if also a pedicle flap from the palate will give enough coverage to the connective tissue graft. I don't know. It's difficult to say. It's difficult to say. With this papilla, I think it's better not to make surgery. Let's say. So if I remove the implant, I leave the soft tissue here, then I have a lot of soft tissue that I can do whatever I like to cover the connective tissue graft. I don't know why you have to connect it. You have to make a graft at the time of the implant removal and to fill a space that should be mainly bone with connective tissue. It doesn't make sense.
We are alone, Giovanni, so we can say to 3,000 people that Italian connection is better than the Spanish connection. We will see what's happened. Oh, here you are.
This is a nightmare.
I'm just talking about the Spanish connection.
Yeah. It is not strong at all. We collapsed as a country. No, you were saying, Giovanni.
Yeah, that in my opinion, it doesn't make any sense to make the connective tissue graft at the time of the implant extraction.
No, it does not make any sense. I agree with you. You cannot leave it exposed. The area of the crestal area, if it's exposed, it does necrose. What can you do? Gain a little bit of a...
It's an enormous amount of graft.
Yeah. Many people like to do it at the time of extraction. I don't see any advantage at all.
I don't see any advantage too, really, because there is no advantage. You feel a space that is going to heal by itself.
Anyway, yeah.
With something taken from the palate.
Yeah.
So why do you have to do it?
One of the
So it really that does not make sense. It's one more surgery, because remember, you are playing with the patient and say, I will make 3 surgery. But if you do 1 at the time of the implant extraction, this is 1 more, because the time of the implant extraction, since it's unscrew the implant, it's not a surgery.
Absolutely.
Yes, you just have to make some anesthesia.
You're increasing morbidity, chair time, discomfort, and the patient is already tired from a failure. So, yeah.
And what do you think about the possibility to unscrew the implant? Do you agree that it's always possible in the upper jaw?
I think we lost also Jose. We are still alone. I make you another question, Giovanni. If we assume there is no bone between implant and tooth, does it make a difference if we remove implant or not? If there is no bone between implant and tooth.
If there is no bone between the implant and the tooth, we have to remove both. So there is no bone distal to the implant, so it means that there is a lot of thread, interproximal thread of the implant that is exposed from the bone, and the same is mesial to the lateral. So it means that this is a defect that cannot be regenerated. So most probably the only solution is to extract both, to make bone augmentation, soft tissue augmentation, 1 implant and 1 cantilever. This is in my opinion. So if there is no bone at all, I would say that it's better to extract. Then we can discuss if you can extract the implant and the tooth the same day, or you can extract one, then leave some healing, and then to extract the second tooth, the tooth or the implant some period after, just to be less traumatic the same day, but maybe it doesn't change so much. So for sure, if there is no bone, so by orthodontically increasing the space, you see that there is no bone distal to the implant, that there is no bone mesial to the tooth, I think that both of them has to be removed.
Okay, and if there is bone, in the case there is...
If there is bone, we will see what Iñaki did, if he's still with us.
Yeah,
because it's very important, because if there is bone, it means that the papilla will improve also. And so there's a lot of things that you can do. Obviously, you cannot regain the amount of bone the tooth has lost horizontally, but by making orthodontic extrusion, eventually after, you can improve a lot. Also the level of attachment, the level of the papilla mesial to the lateral. The only problem of this lateral, in my way, by making extrusion, not immediately, but after the first healing of the soft tissue, is that the root is very short. And so even if you improve the papilla by extruding it, the amount of root remaining in the bone is very limited. And this is, a compromise. But everything is a compromise.
Okay, and what about the possibility to cover this implant with a sticky bone, and then
Jose came back.
I think so. I hope.
Okay, there is a little bit of delay.
Yeah.
2 people connected now. So we are waiting for Iñaki, and then.
There was a question for Jose. What about the sticky bone? I don't know what it is.
The colleagues are writing about the possibility to cover the implant with a sticky bone, and then to in order to gain volume and to reshape the crown, and then a good proportion between the pink aspect and white aspect of the aesthetic area. So they think that we can gain the papilla with the bone regeneration.
I don't think so.
Okay, it's clear. And so we can also.
I have to tell you that I would be, despite everybody saying that you can unscrew the implant in the upper jaw 100% of the case, I'm really very, very worried when I have to unscrew the implant that is so long, it's so wide, because if in the case it's not working during the removal of the implant, and you have to remove it surgically, and you are so close to the lateral, so it becomes a problem. So you have to tell me 100% that you are going to unscrew it. And so implant extraction in this case would be my good choice once the papilla is improved.
Yeah, in fact, Giovanni.
But I have to be sure that.
I'm sorry. No, I was telling you that my decision on extracting would be also based if I'm able to remove it flapless, easily. If not,
absolutely.
I would never get into that mess.
In this case, I don't elevate the papilla. Even me, I don't elevate anything in this case.
I can read the question from a
really
colleague.
Flapless, but you have just to unscrew.
Yeah.
And what's your opinion? What's your experience with unscrewing the implant in the upper jaw? No problem, even if they seems to be very integrated and very long.
I have to tell you that it goes also from different implant brand.
Alberto,
Giovanni, I don't know. So in this time, can I talk about our program of the Society Italian Academy of Osseointegration in this period and also in the future for the next president that you are? So in this period, Alessandro, may I show? Can you show the picture I sent you? Oh, okay, perfect. In this time, you can go to the www.iao-online.com, and so you can free for free and access to many lectures and live guest discussions and other discussion like this, all for free. And this is a big society of Italian surgeon and implantologists that want to share in this period all our expertise with the people that want to access to our website. So we're waiting for you. And also we're waiting for the next appointment of our big society in January, in 28th and 29th of January. I'm right, Giovanni, if for your your big
the last weekend of January.
the last weekend of
there
January
will be the first event of my presidency, and it will be really like a match between two surgeons that apply different surgical approach for the same goal. For example, like today, papilla elevation or vista technique for the treatment of soft tissue lesions, and then we will see what happens. But now it's time to go back to our clinical case, because please trust me, it's better if you stay here, because you cannot imagine how this case was solved. You cannot imagine.
It's an unbelievable outcome. It's really an unbelievable outcome. You guys have to stay and watch it, because I mean, I have learned so much. I think Giovanni, you as well. I mean, we could never imagine the outcome.
Yeah, I'm so sad that was the case of Iñaki, that you cannot imagine.
I can show you another picture
I'm
of
so
the.
sad for this.
If you want,
Alberto,
you can show the before and after.
Before and after, yeah?
You do, please do.
Are you ready?
Now is the time.
Okay.
Now is the time.
Okay, perfect. 3,
now it's
2,
the time.
1.
And then we can say this is a case of Zucchelli and it's finished.
This is the final picture of the case.
It's really unbelievable.
Unbelievable.
As you can see, perfect papilla from both sides.
Unbelievable. Now it's perfect, everything.
So let's see what the people think. He maintain or he remove the implant. We will see. Will you tell us this case out?
Alberto, non è meglio che ti fai dare la presentazione, la fai vedere tu e lui si collega?
Non riusciamo a raggiungere al telefono.
The audience can guess. How did he manage this? How did he do?
Altrimenti lo diciamo noi.
Iñaki said he maintained the implant.
No.
And he used ortho.
No, okay, say how. Ortho involved.
Ortho involved, you're right. Ortho was involved.
You see that look at the inclination of the lateral, how much it changed.
The people said Photoshop.
Yeah. Looks like. I mean, we've seen, and you guys will see the step by step, and you will believe that it is not Photoshop at all. But it looks like, because it's unbelievable.
I guess you can say now if he maintain or remove the implant.
Giovanni was mentioning something very interesting. You see the root angulation, and you see the position of the lateral incisor. It's just the opposite as what we had. The root was pointing the implant. Now the root is pointing the canine. Plenty of space. Plenty of space. So he maintained the implant. Yes, he did.
Yes, he maintained the implant. Absolutely. He did free gingival graft. I think
connective tissue.
Connective tissue. 2.
He did first, the bacillus. No, he did the connective tissue first.
Yes.
Yep. Then he changed the inclination of the lateral only, leave the soft tissue of the papilla increased for many months. Then he did the second surgery, which was the coverage of the head of the implant with another connective tissue graft taken from the tuberosity for sure. But it was nice to discuss how he was able to cover. That was my biggest question in this case. And then he did extrusion of the lateral in order to improve the papilla height after the second surgery and to reach an incredible level of the papilla between the tooth and the implant. But the only drawback, if there is no drawback, is that if you see the X-rays at the hand, there is only very, very small amount of root into the bone because the lateral was very, very short. But this is not a problem because even if in 25 years' time he is going to lose the lateral, this is a perfect pontic for the implant supporting the lateral. There is already the papilla. Everything is perfect. So
I can show you the
best
final
treatment,
X-ray
because
if
when
you
you
want.
see such an outcome, this is the best treatment.
It is certainly unbelievable.
This is the final X-ray.
Okay, show the X-rays.
Yeah, make it wider, Alberto, if you can. Yeah.
Okay.
Can you? Yeah, thank you.
This is the X-ray.
And you see that this implant really didn't lose any really amount of bone distal, and it was incredible because if you look at the X-rays that before, it seemed that there was no bone because of the very, very, very close proximity of the tooth. But there is only one thread that is exposed from the bone distally. So it's really an implant that is going to last, I don't know how many years.
Yeah. What it's also...
And the lateral, it's good.
Yeah, the lateral is good.
Yeah.
Very little probing, he said, and it's good. What is also amazing, Giovanni, is that by doing a second connective tissue graft on the occlusal area, he's able to distribute and gain tissue on the papilla. I mean, thickness, but also on the papilla area. And
height.
Exactly, height. And the technique he used for the second connective tissue graft, I mean, I hope the audience will be able to see it because it was a very, very fine and difficult surgery. Coming from very far and leaving all the occlusal area. I think it had a lot of merit.
The people are,
so sorry.
Are asking how many millimeters in the bone is the lateral. And they are thinking how is the prognosis of the lateral.
Well, what's the problem with this? The prognosis of the tooth does not depend on how much bone you have in the tooth. So this tooth is the only problem with this tooth is that the mobility of this would be so different with respect to the implant that it was correct to splint, in my opinion, with the other teeth. But I don't think that even if there is a root that is short, this will change so much the prognosis of this tooth. The problem is that there's no probing pocket depth, that there is a healthy tissue.
I agree, Giovanni. The prognosis is being given, especially by the probing depth there. Like he said, it was rather shallow, and mobility, and it's splinted, so it will last forever. Yeah, he's able to clean it. He's able to floss in that area.
Yeah. The only problem is the very, very different mobility between the tooth and the implant, and that's why it has to be splinted.
Yeah, absolutely.
So this, I have to tell you that the incredible gain in papilla height was achieved thanks to the extrusion of the lateral. So it did, first of all, orthodontic to gain space only. So to change the inclination of the lateral. Then he did surgery. He waited, I don't know, more than 1 year. And then he did extrusion of the lateral in order to improve papilla height once the papilla thickness was increased with the second surgery. So it was really a very, very clever surgery. A very, very clever treatment plan.
Exactly. Yeah. We discussed it the other day that what's the smartest here is the treatment plan rather than the surgeries itself. The treatment plan he executed, giving a chance to ortho, distalizing first, and in a second stage, later stage, extruding is very outstanding. I mean, it's very smart.
I agree. Because if you do extrusion at the same time of change inclination, you don't gain nothing, most probably.
Some people are thinking, I guess it's a new implant, not the old one. For sure, it's the same implant. No, for sure, it's the same implant. No different implant. No.
We've seen it.
Yes, we've been seeing the case, but we don't have now hold the picture of the case, and so we are so sorry that there is no Iñaki, no more Iñaki. So I think after 2 hours of discussion, is it enough for all our audience, and so we can say goodbye to everyone. What do you think, Giovanni and Jose?
Sorry.
We are so sorry. We have to say goodbye to everyone now. I think we can't say anymore because we don't have all the pictures of this case. We can't show anymore.
That's really a pity. I think that you have to do something in order to understand what Iñaki did, because otherwise it's really a pity. You know, we just say what he did, but it would have been nice to discuss how he did and
maybe
how he did the surgery, etc., etc.
We can organize maybe.
I don't know. Please do whatever.
We can organize maybe another discussion. Another one just for the Spanish connection doesn't work, Giovanni, so we can say, possiamo salutare in italiano tutti i colleghi che ci stanno salutando dall'Italia and also say goodbye to all the people from all over the world that are watching now. We are waiting for you in the... Oh, Iñaki!
Yes, sorry.
Here we are. It's incredible.
I was in and out. Yeah, I don't know why it went off.
Where were you?
I don't know. I was out for a moment, so
you guys.
I don't see you. Do you see me?
Yeah. Yes, I see you. Yeah, okay. Now you can share your screen.
Okay, share your screen.
In Italy, we say Zona Cesarini, just in the last minutes of a match.
Yeah, I don't know. I cannot join. I don't know why.
You can share the screen now. You can share your screen. Okay. We will try another time. There are many of you, 2,000 and half, that are waiting to see all the surgery. I'm so sorry, guys.
To join, I don't know why.
I don't know. Are you using the Chrome?
Yes, I'm using the Chrome.
If you...
I think so. Just I'm gonna get out and come back again, okay?
Yeah, try. José.
So we might get it.
Podemos hablar un poquito en español ahora por la gente que está siguiendo la transmisión de la España.
Sí. Claro que sí. Me sabe muy mal los problemas de conexión que estamos teniendo.
¿Y por qué?
Guys, I'm really sorry about the connection issues we are having. I don't know. Well, Iñaki and myself, we are struggling, but we're getting out. Estamos perdiendo la conexión. No sé el motivo. No, una cosa muy poco habitual.
I think we are...
Cosas del directo.
Exactamente. Sí. Alessandro, can you show the screen of Iñaki?
I see José.
I
can see
myself, but I don't see anybody else.
Alessandro is okay. We can see your screen, so maybe you have to open the presentation in the same screen of your Chrome website. Okay, in the same screen.
Yes, I did.
Okay. Now you can close and click on the X.
Yes.
And then share another time. So try to start the presentation. We can see anything now. Go ahead. Really, thank you, guys. You are still here. I can understand. Eccoci. Vi sento molto male. Alessandro, tu ci puoi sentire? José?
Perdóname. I'm back.
Yeah, don't worry. We are here. The connection also in Italy from Bologna it doesn't work now.
Yeah, we don't know what's going on. I mean, it's very surprising and it's very annoying at the same time. So I really feel sorry for the audience.
Yeah, don't worry. They are still here, 2,000 and half. They are still waiting for Iñaki. So we We can see.
I mean, it's worth. I'm telling everyone, please stay. The case step by step is just beautiful. So it's worth 5 minutes waiting, because you're going to learn quite a lot. Sí que
Iñaki.
lo puedo decir en español. Iñaki está.
Estoy aquí, ¿no? Do you see me?
Yeah, perfect. Also, if you can't share the screen, you can explain us how do you solve the case. Also, if you can see the picture, you can explain us. So I show the final picture and a final X-ray. So all the people now know that you maintain the implant, and they can't believe how do you maintain the implant. And also, they want to know, in your opinion, how is predictable the maintaining of the lateral incisors?
Well, I think one of the.
Can you explain, sorry, step by step what you did?
But didn't you see it on the? Did you see my presentation?
No, we can see your presentation. I'm so sorry. I don't know why.
So you didn't see what I did?
No, we see only the final picture. Okay. So, I don't know. Here we are. We are waiting for all the panelists. I'm just here. I'm the moderator, and so I don't have to be here now. I'm only a voice to make a voice to your question. I think that we can wait some minutes, but then after a few minutes we can close this online discussion. It's really incredible that you are still here and waiting, because in internet, when the connection doesn't work, all the people go away, go ahead in another web page, and so you are still here. So thank you. Giovanni, I asked to Iñaki to explain exactly how he solved the case. Also, if we don't have the pictures. So sorry, guys. I can talk you about our society. So all that you see in this case, in this online discussion, case discussion, we did other 4 preview events like this, and so you can, if you access to our webpage, you can see the lecture, the live surgery, and you can exactly know when there are our events. So we are trying to organize now an online congress, so also in English, and so you can participate in June and also in October, and we hope that in January we can have we can meet each other like in the past, so we can hug and stay all together. So all the people say that it's better than a Netflix series at the final episode. You leave me alone, guys. You are the panelists. I'm only the moderator. Let me see. They are still here. More than 2,000 people are listening to me. Hello, Matt said, the fact that we can be in our homes safely watching 3 different intellectual philosophies is amazing and testament to how good we have it. Perfect, quindi you did a good job, guys. At the moment, I cannot listen anything. I'm still here, and I think that we have nowhere to go. Okay, Stefano. Giovanni, can you hear me?
Yes. I'm so sorry, really. I'm so sorry.
No, I try to smile to all the people, and
but so Iñaki,
the connection doesn't work also in Bologna. A few days ago, Milano was the worst place in the world for the coronavirus, and now is the best place for the connection. Also, if we compare it with Bologna and then also with Spain. Vittorio said that wants to see the final case. So, and then Eva, I'm here till the last. I'm so sorry, and thank you, guys. So maybe I can show you another time the presentation that we just shared before. So if someone of you didn't see the first picture, can see it another time. Let me see. Okay. I can show you another time. This is the first picture. Alessandro, can you show half my screen with the picture and the other half with the activity of Italian Academy of Voice Integration? So, and instead of me, you can see also the picture of the Italian Academy of Voice Integration, the photo with Guido Giordani. Okay, on the right of your page, you can see the live guest, Guido Giordani, that is an online webinar in English, and so you can participate. It was organized by the young group, and so we can jump into the case through the case, please, with my screen. Alessandro, please, can you share my screen? Oh, Jose.
I'm back. What about the other?
And remove also your Prime Video. I think that we can conclude this online discussion with to be continued. What do you think about this? And we promise to our audience to come back here in few days for a few minutes just to solve the case.
Let's do it. I think it's worth seeing step by step, learning from every surgery he did, learning from the ortho movements. These were very smart.
Yeah.
The distalizing of the root, distalization of the root first, and then at the very end, the extrusion. I think it's very well performed. You see the braces, you see the wires that were used, but the connective tissue grafts both are very well performed, very neat and very smart. The approach he did. He didn't raise the papilla once it was created, and then you will like it. The first one and the second one on the crestal area.
Okay, perfecto. Please.
A ver, ayúdame ahora.
Is Iñaki back?
Porque yo le digo aquí.
Is Iñaki?
Yes.
Le digo aquí pego para enseñar, ¿no?
Can you remove my video from the screen, Alessandro?
No hace nada.
No, remove my video and.
Intenta de reiniciar el sistema. Vale.
No.
Cierro.
Iñaki, okay.
Cierro.
Iñaki, can you hear me? No. So sorry, guys. I'm so sorry. Do you want to see I think that we can stop here this broadcast, and then we go live another time to solve this case. What do you think about this? We can wait just 2 minutes and then we can go. More than 2 hours, guys. I'm so sorry. Okay. So thank you so much for being here. I was very honored to moderate the discussion. I'm so sorry for the because we didn't finish. We don't finish the case, but I promise you, in a few days we will solve this case, and so we can connect to our broadcast in order to see all the steps of this case. Thank you, guys. Bye.